Hi everyone, this is our pharmacology project by Jamie, Kristen, and Nicolette. Enjoy!
Let's take a moment to learn about schizophrenia. Schizophrenia is a psychotic disorder. It is the most common among the schizophrenia spectrum and other psychotic disorders. The characteristics of schizophrenia are hallucinations, delusions, disorganized thoughts resulting in disorganized speech, catatonic behavior, and negative symptoms. Schizophrenia literally means shattered or fragmented personality. It seems to be fitting if you take a look at some of the diagnostic features. For example, people suffering from schizophrenia will experience a disturbance of functioning in their workplace, interpersonal relationships, and/or self-care. People suffering from schizophrenia will also find a difficulty in making sense of the world around them. They may place non-reality-based meaning to common situations, sinister attributions, and respond with unusual behaviors. They will also focus on information that is irrelevant and minor to the situation at hand. It may be difficult to comprehend someone experiencing schizophrenia.
The causes of schizophrenia are not yet known. Evidence supports that there is a genetic and environmental influence on the disorder. For genetics, evidence suggests that schizophrenia is a genetic disorder. Studies show parents and siblings of those who have schizophrenia are at an increased risk at 10% of developing schizophrenia, while those who are more distant, such as cousins, have a 3% chance. The next component that affects etiology is psychosocial. Out of the amount of studies, there has been one that stands out. The amount of tension within families is the most crucial variable that affects this disorder. Studies show families with high expressed emotion, HEE, in terms of patient relapse, were significantly higher than those with families with low expressed emotion, LEE, even with other factors such as medication compliance. Biochemical is the next component of etiology. Firstly, there's the dopamine theory, which is the most widely considered theory. Symptoms of this occur when there is an excess of dopamine and its receptors are overstimulated. However, this is not believed to be the cause of schizophrenia. Studies in antipsychotic drugs show an increase in glutamate neurotransmitters as well. Finally, etiology looks at brain chemistry. In some studies, it is shown that males with schizophrenia may have larger lateral ventricles with the potential of having 3. Another study showed that frontal lobes of patients with schizophrenia metabolize irregularly compared to those who do not have schizophrenia. Further testing also indicates that those with schizophrenia show lower frontal lobe capabilities, which may indicate why there are cognitive and psychosocial impairments.
Let's learn a little bit more about dopamine and its role in all this. Dopamine is a neurotransmitter produced in the substantia nigra. Its neurotransmission controls a lot of our everyday lives in the form of movements and reward-motivated thoughts and decisions. Schizophrenia acts from the overloaded dopamine being transmitted into the central nervous system. The extreme amount of dopaminergic neurotransmission causes overstimulation of the dopamine receptors, resulting in some of the motor and thought malfunctions. This is where antipsychotics come into play. Antipsychotics block some of the dopamine receptors. This results in a decrease of dopaminergic neurotransmission and a regulation or decrease of linked symptoms. For example, there are 5 dopamine receptors on this axon. Originally, this was allowing an abundance of dopamine to be transmitted. However, when we can get an antipsychotic, it's going to block some of those receptors, allowing our available dopamine to be regulated, and in this scenario, only have 2 of those available 5 receptors to be transmitted.
For choices of medication for antipsychotics, there are 2 different categories. The first one is conventional and the second is atypical. For conventional, it can also be known as first generation drugs, and they came about in the 1950s. 20% of adults with schizophrenia are unresponsive to first generation drugs, and there are 4 different options of the conventional generation. The second category, atypical, or can also be known as second generation because it came after the first, came about in the 1990s. They came about in response to the side effects of the first generations, and that not as many adults were responsive to the first generation, so they gave these ones a try. And there are 10 options for the second generation. So altogether for antipsychotics, there are 14 different options you can choose from, which seems like a lot to me when I was researching this, but gotta have your options, I guess. The first conventional drug I'm going to talk about is thorazine. You can take 60 milligrams to 800 milligrams a day if you're a typical adult. You could also possibly suffer from ESP, which is a major side effect that comes from conventional drugs that I'm going to address more later in this presentation. The next conventional drug I'm going to talk about is Haldol, and for the dosage for a typical adult on this one is 1 milligram to 40 milligrams, and then you could also have the risk of suffering from ESP. And again, to our right, you can see the bottle of what Haldol would look like if you went and picked it up from the pharmacy. The third conventional drug is Navain, and you can take 10 milligrams to 60 milligrams a day. These dosages for all these drugs differ based on what your doctor prescribes you, so that's how that's determined. The last conventional drug we're going to talk about is stelazine, and you can take it for 2 milligrams to 40 milligrams a day. Now I'm going to start talking about the side effects of the conventional drugs. So the first 4 that I have up at the top, I'm going to explain more, and the bottom 2 PowerPoints don't need as much explanation, so you guys kind of know what those are all by yourselves. But the first 4, the extrapyramidal symptoms, those are the ESPs that were listed on all the conventional drugs. So extrapyramidal symptoms, they're known for movement disorders that include acute and iterative symptoms. There's more specifics, and I will talk about that later. Then we have orthostatic hypotension, which is a form of low blood pressure that happens when you stand up from sitting or lying down. You can start feeling lightheaded or dizzy. There's blurred vision with that, weakness, fainting, confusion, and even sometimes nausea. And then the next thing is increased levels of prolactin. So prolactin is a hormone that usually comes about when a woman become pregnant. So if you have an increased level of it, for a woman, you could have irregular or no periods. Infertility could happen if you have a high level. Breast milk discharge when you're not pregnant or nursing. A tenderness in your breasts. Hot flashes are another thing. For men, you could have a decreased sex drive, difficulty in getting an erection, breast tenderness or enlargement, and breast milk production, which is very rare, but it could happen. For both sexes, you could have unexplained headaches and vision problems as well. Then the last side effect that I'm going to discuss is neuroleptic malignant syndrome, which can cause high fever and muscle stiffness. This is a very serious condition, but it is treatable. Most people who get it make a full recovery when it is found early. Then we have at the bottom weight gain, particularly with the Thorazine, and then you can have dry mouth, blurred vision, constipation, and memory problems. So these are all the side effects of the conventional drugs. The first side effects for conventional drugs that fall under the ESP category is dystonia. It's muscle tightening in the neck and shoulders accompanied by spasms. The second one is Parkinsonian, and it produces muscle rigidity, mask-like faces, tremors, shuffling gait, and diminished arm swing. The third one is akathisia, and it's motor restlessness, a need to move, and an inability to sit still. The fourth one that I have on here isn't technically ESP, but it's very similar to them, so people group them together a lot of the time, and it's tardive dyskinesia, and it's involuntary facial movements involving the tongue, eyes, lips, and face associated with long-term use of conventional antipsychotics. When it is present, it is almost irreversible. Some patients did show slow remission over time, though. The first atypical drug we're going to talk about is Clozaril, which is you can take it 300 milligrams to 600 milligrams a day. Risperidol is also an atypical drug, and you can take 4 milligrams to 16 milligrams a day with this one. This atypical drug is Zyprexa, and you can take 5 milligrams to 20 milligrams a day. This next atypical drug is Seroquel, and you can take 300 milligrams to 600 milligrams a day if you're a typical adult. And now we have Geodon, which is also an atypical drug, and you can take 120 milligrams to 160 milligrams a day. So in the picture, the pills are 60 milligrams, so you would take 2 of those if you're at the lowest dosage of 120 milligrams. And now we have one of the more popular atypical drugs. I say it's more popular because I've seen commercials for this before on TV, but it's Abilify, and you can take 10 milligrams to 30 milligrams a day for Abilify. This atypical drug is called Invega, and you can take 3 milligrams to 12 milligrams a day for this one. This atypical drug is called Fanapt. You could take 12 milligrams to 24 milligrams a day. It's not quite as popular as some of the other ones, but it is still used as an antipsychotic. Sapris is the next atypical drug, and you can take 10 milligrams to 20 milligrams a day. Then the last atypical drug we're going to talk about is Latuda, and you can take 40 milligrams to 120 milligrams. So I heard a silly joke to remember Latuda as an antipsychotic. You can say you need some Latuda for your attitude. The side effects for atypical drugs come with less risk for EPS and TD, weight gain, sedation, insomnia, agitation, constipation, and dry mouth. Some more specific atypical side effects come with Clozaril and Zyprexa. They have been linked to a significant increased risk of type 2 diabetes and an additional risk of increasing triglyceride and cholesterol levels. These risks are referred to as a metabolic syndrome. Geodine and Abilify have low risks for metabolic syndromes, so it's the opposite of the other two. So there are 2 types of treatments coinciding with antipsychotics. The first one is cognitive behavioral therapy, and the second is multiple family work. So with cognitive behavioral therapy, it's similar to what they do to treat depression and anxiety. CBT is APA recommended treatment for schizophrenia. It also is greatly supported for the positive symptoms of schizophrenia, such as delusions, hallucinations, exaggerated, disorganized speech and behavior. An example of that would be that when it comes to hallucinations, the therapist could suggest that the affected person try to increase the volume of the voices. This attempt of making them louder, the goal of this is that if the person insisted that he had no control over the voices, it would then be able to tell the therapist that he was able to make the voices louder and more vocal. The professional could then say, well, if you can make them louder and more intense, let's try to make them softer and less vocal. It would also work for treating negative symptoms, so loss of pleasure, emotional withdrawal, passivity. You can also use CBT for that. It's similar to behavioral interventions utilized with depression. So then going to the second part of this, the multiple family work, that is basically where several family members come together for a counseling session. The session's almost like an educational get-together. For this, it works on problem solving with problems that they all have in common within the family. It also provides social support. Another thing that it could help would be with families recognizes when certain episodes are about to happen with the clients, and proactive strategies they can use, and also reactive strategies they can use. So that is most of the information I have on treatment coinciding with antipsychotics.
Counselor's role in relation to referring a client for medication. First, take in mind that clients will make their own choices at their own time. Don't rush the clients to make a decision. Allow for them to ask questions and be open to discussions. Help prepare them for meeting with their physician if they decide to start medication. Help determine what treatments will help best improve the quality of life of the client. Ensure that there is prevention for clients who want to or are self-harming. Research and know about side effects of potential medications your client might be taking. There are certain things to consider also when referring your client for medication. Some things to consider as outlined by pharmacist and author Joe Wegman. How does the person respond to psychotherapy? What is their medical and medication history? What are their mood and behaviors like? Are they stable or unstable? Are there any psychotic features present? What is the personal and family history related to mental illness? Is there substance issues or use resulting in a disorder? The counselor's role, working with clients who use medications. Counselors should be checking in on side effects of medications and how they might be affecting the client, in case any medication changes are needed. A common issue with those dealing with schizophrenia and medication is medication compliance. Counselors should check in to see if there is a change in symptoms and if clients are taking medications as prescribed. This may explain partly the increase in symptoms. In continuing working with clients, help educate the client about early signs of relapse and help them develop an action plan to promote client safety. Encourage regular doctor's appointments to ensure relapse does not occur. Help identify stressors in the client's life with the client and help brainstorm ways to deal with these. Help the client come up with and find resources to assist them in aftercare, particularly after hospitalizations, to help decrease the likelihood of relapse. Suicide is a potential risk, and counselors should be watching for red flags and ensuring an action plan is in place and meeting with the client frequently to check on them.